Clarnet. I must thank Clarnet for giving us this platform for use for teaching of the DNB students. Develina, you want to start? Today, Develina, we want to start.
Sir, you can start, no issues.
Yeah. So the case will be presented by Dr. Rajat, who is a third-year junior resident at B.R. Singh Hospital. And today we have a eminent faculty, Dr. Chintamani from New Delhi. So he will moderate the session. Rajat, you can share your screen and start presentation.
Hello, sir.
Yes.
I am Dr. Rajat Nandi from B.R. Singh Hospital. This is my case about an epigastric lump presentation due to carcinoma stomach. The patient is Mr. Ansari, a 62 years old male who is by religion Islam and occupied as electrician technician and residing at Asansol belonging to lower middle class. He had a main complaint of abdominal fullness for 2 months, followed by upper abdominal pain for 1 month and central upper abdominal lump for last 20 days. The patient was apparently normal 2 months ago. Then it gradually developed abdominal fullness after feeding, which has moved to solids and liquids, and more pronounced after a fatty meal. There was occasional postprandial vomiting after 45 to 50 minutes of food intake containing the last ingested meal. He is also suffering from pain over central upper abdomen over last 1 year. It was insidious in onset, gradually progressive, delicate in nature, and seldom occurring for long durations. There was no periodicity of the pain and not radiantry to our other parts of the abdomen. The pain was aggravated after feeding, mostly due to distension, and relieved after taking analgesic medications. He then noticed a lump in central upper abdomen the last 20 days ago. It was gradually increasing in size with time and being more prominent after feeding. There was no history of similar abdominal lump in his any other family members. He also suffered from anorexia and weight loss over the last 1 month, which was actually evident by gradual loosening of his garments. The patient has been gradually weakened, and now he is unable to perform his work activities. There is no associated history of hematemesis, melena, hematochezia, jaundice, or something moving side to side in abdomen. His bladder and bowel habits are within normal limits, and there is no history suggestive of any distant metastasis. Now, going to the past illness, the patient is a known diabetic for last 12 years and a known hypertensive for last 10 years, for which he is taking oral medications. There is other no operative history undergone by the patient. The patient is addicted to cigarette smoking for last 30 years and smoked about 7.5 pack years. He often skipped his meals due to work pressure and substituted with drinking chai or spicy foods, but there is no history of alcohol in it. He is married for last 35 years with 2 living sons. His father and mother both have died 16 and 10 years ago respectively due to geriatric conditions, and there is no history of similar diseases in the family. Now, going to the physical examination.
Wait, Rajat, wait. Let's go through your history part.
Okay.
Right, Rajat's very nice history. Now, I'll go backwards. What do you actually understand by that none of the family members had a similar illness?
There may be, due to carcinoma, it can be genetic in nature, and every cancer.
So to save time, that's not how family history should appear. Because when you're taking the family history, you have something very specific in mind. So you're looking at familial conditions or hereditary basis to the problem. Am I right? So you can be more direct rather than just being lazy about it, that nothing of this kind in the family, which is left to everybody to imagine as to what does he have firstly and then what can the family have. Okay, so that's one thing. And usually, otherwise you've covered all aspects. You mentioned a little bit about the pain. I think pain happened later, no?
Yes, sir.
So if you were to put it down in the chronological order, what did the patient have first?
The fullness, abdominal fullness.
So fullness or satiety, as they call it, when they feel full, and followed by
The pain, and then the lump.
so you can understand the march of the disease, because lump would be much later, which he can appreciate. You could have well appreciated much earlier, but then he is not a clinician, so he can't actually examine his lump. So that is falling into place. And then you mentioned that he took meals, and after 4 hours, the patient would have vomiting. Am I right?
Yes, sir.
Now, that also needs to be very clearly highlighted, because otherwise there's nothing much in the story. It can be much simpler. So you mentioned there was occasional postprandial vomiting after 40 to 45 minutes of food intake. I'm sorry, 50 minutes of containing the previous ingested meal. Previous means yesterday's meal.
If this is postprandial vomiting, that is the last ingested.
So actually, this is still the meal that he had taken 45 minutes back. Am I correct? So it's
Yes,
not
sir.
the last day. It makes a difference. What is it? What is the significance of this?
The outlet obstruction, if there is any.
And sometimes there can be, some physiological problem with the conduction. You'd like to know about achalasia or other conditions, or there is a gastroparesis of some kind where the food may be there for a longer time. So we are interested in knowing it. And then about the vomiting. What kind of a vomiting was this? Well, all you have described is it contained the food taken 45 minutes back. That's it. But the vomiting can be elaborated further. Could you tell us more?
If it was a non-projectile in nature,
Right.
associated with a nauseating sensation previously, and
Did it relieve that pain?
yes, sir.
You mentioned pain was periodic in nature, not radiating, aggravated after feeding, and relieved after taking painkiller medications. So this is like a copybook story you're giving us, but usually this act of vomiting leads to relief, because the cause is obstruction, where if there are contents in the stomach is trying to push it down, and there's an obstruction, so there is a positive pain usually. While your pain is dull, aching, persistent pain. So to put it in the right perspective, one was the history of how the pain happened and what kind of pain was it. You mentioned about some no radiation, etc., but its relationship with that vomiting that you're mentioning, because that is important. And in addition, what all did the vomiters contain? You mentioned that it is a previous meal, which would mean almost undigested. Am I right? And did it
Yes.
smell? What would it mean if there was a foul smelling vomiters? See, the longer it stays, more likely that it can be foul smelling. And rarely, if there is a fistula, gastrocolic, or anything else, that you will have, foul smelling vomiters. Can you hear me?
Yes, sir. Yes,
Yes, sir. You're audible, sir.
Yeah, okay. So pain was not periodic in nature. Why are you trying to mention that? Not periodic. Hello?
In fact, Rajat, 1 month is a very short period to comment about periodicity. Periodicity comes in a pain which is there for about 6 months, 1 year, so longer duration. So periodic term should not be used in a history of pain for 1 month.
Oh, yes. Okay.
Was it colicky?
No, sir. It was actually developing in nature.
I know you have written that. So you see, I mean, when would you get a colicky pain?
If it's obstructive, some kind of, and the patient,
So
the physiology is trying to push it back.
Agreed. So you're linking it to the obstruction, and you're not able to qualify that. your vomiting, you're also linking to obstruction. Am I right? Gastric outlet obstruction. But you're not able to qualify that. So basically, history should not be as it is, as it was presented to you by the patient. Then you can ask some questions and make it more relevant. That is what I was trying to say. Right? Because it is in your history and examination that we'll be able to assess whether you understand your subject or you don't. Yeah. Now the pain
Okay.
was dull aching. Am I right? So this
Yes,
would be
sir.
persisting all the time. What would be the cause of dull ache? Not obstruction.
The mass itself, and the cause,
So the
and the
disease is there,
distension.
correct? So that disease is there all the time. So why should it go away? Are you getting what I'm saying? So sometimes please understand the description
Yes,
of
sir.
pain by the patient may not be in the classical colicky style or dull aching style, and we try to take the middle path by calling every pain dull aching. So be careful about it. When a patient has a classical gastric outlet obstruction, it is related to the meal. It's followed by vomiting, and vomiting relieves this pain at least partly, and then it can still persist because there is a lump and there is disease and it is stretching the stomach. But these points should come out in your history. Okay. And when you're saying painkiller medications, so naturally, it is some painkiller that you will have to highlight. Is it some antispasmodic or it's just a?
This is the patient's history, and patient says he took some over-the-counter painkiller medications. So we
Because
cannot actually specify.
sometimes, in the good old days, when we were describing a colicky pain, we would usually mention it as a waxing and waning pain, coming in waves, relieved on application of pressure, and also on the intake of antispasmodics. So they would link it. So there it could be helpful. Anyway, I think that was about your presenting complaints. Now, in the family history, I'm sure you could have asked for more questions. And in the weight loss you mentioned, I mean, the family history, otherwise, you mentioned that the parents died due to geriatric conditions. So there's nothing familial you're associating. And when you're using the tired language, there's no history of similar diseases in the family. What are those diseases?
What familial cancers are important in patient of carcinoma stomach?
There will
Do
be
you know
stomach
some
gastric
defined
cancer,
syndromes?
and the Peutz-Jeghers syndromes, and the DHL syndromes. Many syndromes are there actually.
Any relation to breast cancer?
The patient can have breast cancer and stomach cancer in the same family.
Because what the sir is asking, you must be knowing the genetic history of the
Yes.
patient family to ascertain whether this is a familial predisposition or not. Okay, just writing one line is not enough.
Let's go to the examination, dear. Now, what is your impression so far? It's a takeaway case. So, what impression still do you make based on history alone?
There is a stomach mass with distinction.
Elderly gentleman,
Distinction
satiety, fullness.
Right. So
Lump.
basically, you would be coming out promptly. You wouldn't be going, again in those bits and pieces. It's an elderly gentleman with an epigastric pain and a lump and a mass with features of gastric outlet obstruction with associated significant amount of weight loss. I would err on the side of calling it a malignant condition in that region, and the organs I have in my mind include stomach and others I'll see as I go along. So you're looking at upper GI as a organ of origin or disease, or the organ affected by the disease. Am I right?
Yes, sir.
Right, Rajat. So let's move to examination now.
No, sir. In the general survey, the patient was actually fully conscious with perfect orientation of time, place, and person. He was of average build, but with poor nutritional status. If the patient's attitude was lying still and decreases as per patient's choice, the patient was slightly forward recumbent on standing. The faces was normal. Her color of skin was slightly dark. There was mild pallor, but there was no icterus, cyanosis, scrubbing, or edema elicited. Her pulse rate was 72 per minute, regular in rhythm and normal in character and pulse. There's respiratory rate of 18 per minute with normal rhythm and no respiratory or expiratory prolongation. The temperature is 97.8 degrees Fahrenheit and blood pressure was 136 by 88 millimeters of mercury. Now, going to the examination of abdomen. On the inspection, the
I
abdomen
think
was
let us take, hello, Rajat, let's
Okay,
take
sir.
general examination first, because otherwise we'll miss it. Like in history, we have to go back.
Okay, sir.
When you're describing general survey, right?
Yes, sir.
The mental state cannot be ascertained by just these two facts. So there is no point mentioning it as mental state. Patient is conscious, oriented to time, space, and person. That's it. You don't have to describe that as you don't declare mental state. That's required so that your history can be trusted. When you're asking somebody any story about himself, the patient should be alert, conscious. That is what you're trying to say. By this, you're not ruling out any CNS problem. Okay, so be careful about it. And when you say nutrition is poor, what do you mean by that?
Poor skin fold thickness and low body fat contents, cachectic look.
So did you do that assessment?
Yes, sir.
Or by gross look, or by gross look, you said it.
No, sir. We have to measure the mid-arm circumference and the skin fold thickness by vernier calipers.
So what I'm suggesting is you should have done it. I mean, at least the anthropometric assessment, which you can do clinically. For the calories, you will do BMI. For the proteins, you'll do mid-arm circumference, pedal edema, anemia. And for fats, you'll look for the skin, tricep skin fold thickness, and that would be accepted. The patient is vomiting, and nowhere your hydration status came into picture. Now that becomes important in general examination. So where would you look for hydration in this gentleman?
If the tongue is moist or not.
The tongue is a very false positive or a negative place to look for it. Any other sites? Because sometimes the patient...
Skin rigidity.
Skin turgor. Skin turgor, where would you look for it? Anywhere where you don't have too much of subcutaneous fat, etc. So, this is important, sir.
Thank you.
Because actually, hello? There can be an issue. So if the hello.
Hey, other people mute, please.
Evelina, can you please
mute yourself, please?
Evelina, can you please mute the other participants?
না থাইরয়েড বেশি ছিল পেশেন্টটি হাই রিস্কের কনসার্ন দেয়
So Rajat, can you hear me?
Yes, sir, I can hear you.
Host
But this is getting actually noisy.
Off. Other people, please mute. Exit the speaker, please.
Okay, I think we can keep moving while it is happening. So I hope you understand that. And
Yes, sir.
you need to look at the skin turgor. Sometimes they've got a nasogastric tube. They are mouth breathers. The tongue can be coated, and you may get a false, negative report or a false positive, depending upon how you're looking at it. And then the other thing is you don't write decubitus is of patient's choice. Describe the decubitus, which you did. What is the decubitus you mentioned? Next slide. I could read something. When he's standing, how about when he's lying down? Is he tossing in the bed, holding onto his tummy? Is he coiled up? That becomes important. Now, the rest is by and large all right. You don't have to describe the color of skin and other things. They are not important. I would be more interested in generalized lymphadenopathy if it is there, and fecal edema and other features you have already described. Next slide. So these are your cardinal signs. Don't mention cardinal, just describe the why. All are cardinal. There is nothing like a cardinal sign. Pulse, respiration, temperature, blood pressure. So don't coin these terms. Just mention the pulse, blood pressure, temperature, respiration.
Yes, this is a part of general examination. That's it.
So you don't have to highlight unless.
Yes.
Okay, let's move. I think I need to mute this particular or lady Rooplekha Ghosh. Rajat, can you move on, please?
Yeah. Okay, sir. Now, going to the examination of the abdomen part. On inspection, the shape was neither retracted nor distended. The umbilicus was inverted and just below midpoint between xiphisternum and symphysis pubis. The skin showed no scar, any visible swelling, or engorged veins over abdomen. There was no visible peristaltic movements over abdomen. The hernial sites were obvious. There was no obvious swelling in hernial sites and no visible cuff impulse. The external genitalia was circumcised without any other visible abnormality. Now, going to the palpation part, the abdomen was soft in feel and non-tender. There was no rigidity or distension as such. The hernial sites were no palpable cuff impulse or any lump. Now, on the palpation of swelling, there is an intra-abdominal lump as evident by the head rising, which was non-tender on palpation. The lump was located at the lower half of epigastrium and the upper half of umbilical area, measuring 5 centimeter vertically and 7 centimeter horizontally, with a globular shape, an uneven surface, irregular margin, a firm consistency. The mobility was present across vertical and horizontal axis, and the swelling was moving with respiration. The liver, a smooth surface, sharp margin, non-tender, and dullness appeared from the 6th intercostal space in the midclavicular line, and liver was palpable 3 finger below costal margin, with an estimated liver span of 14 centimeters. The spleen was not palpable by finger insinuation test, and there were no other palpable organomegaly denoted. On percussion, there was no shifting dullness. The percussion note over the swelling was dull, and no palpable hydrated thrill. The auscultation, there is normal peristaltic sounds of 6 to 7 per minute. There was no arterial bruit over the swelling. No succussion splash was evident. And on auscultopercussion, the stomach is not enlarged. Now, going to the digital rectal examination, there was no anal tags, sentinel piles, scar, fistula or sinus visible in the perianal skin. There was no palpable swelling or abscess, and no palpable mass inside anorectum. Soft stool was palpable inside, but there was no active bleeding or blood clots. The left supraclavicular lymph node was not palpable. And on the general examination, revealed normal respiratory, cardiovascular, neurological, and lymphatic system without any palpable generalized lymphadenopathy. Now, to summarize, this is a 62 years old gentleman who is diabetic, hypertensive, and smoker, presented with postprandial fullness and occasional postprandial vomiting for last 2 months, with upper abdominal pain for last 1 month and upper abdominal lump for 20 days. There is associated anorexia, significant weight loss, and gradual generalized weakness, but there is no history suggestive of distant metastasis. The general survey was essentially normal, except poor nutritional status and mild pallor. On inspection, there was no visible swelling, but the umbilicus was just below the midpoint of symphysis pubis and xiphisternum. On palpation, There was a 5 into 7 centimeter firm, globular, non-tender intra-abdominal swelling at lower half of epigastrium and upper half of umbilicus, which is moving with respiration and mobile in vertical and horizontal axis. On percussion, there was dull note over the swelling and no hydrated thrill was present. There was no elicitable shifting dullness. On auscultation, there were normal peristaltic sounds without any auscultable suppression splash. Digital examination was rectal examination was in normal limits, and there were no palpable left supraclavicular lymph nodes. So, my provisional diagnosis is this is a case of epigastric lump, probably due to carcinoma of stomach.
I think we need to look at your examination of the abdomen from the very beginning. Can you go back to the slide? See, first thing is don't try to make it very regimental. You can be quick with many things, which you are unnecessarily wasting time. So what is the normal position of umbilicus?
Midpoint between ciphisternum and symphysis
Why
pubis.
should you then unnecessarily waste our time describing that it is in the midpoint? So it's normal, inverted, right? The abdomen is
Okay.
not distended. That's all.
Yes, sir.
There are no visible scars, sinuses, and gauge veins over the abdomen, and there's no visible peristalsis. Next slide. Hernial sites are normal.
Okay.
There's no fuss about it. And yes, external genitalia you want to emphasize, since he's a Muslim, circumcised, etc., etc. No abnormality. That's what you're looking for. But what was more important was that the testes are felt normally, which is what should be relevant to you. No, rest may not be relevant to you. Why should I talk about testes? Because if there is an undescended testis or there is a malignancy associated, it could be an epigastric mass. Can happen, right? You know what I mean.
Yes,
Now
sir.
coming to feel is this, no, just be in a flow, soft, non-tender. If it is non-tender, highly unlikely to be rigid. So all hernial sites you're again repeated. Once you've checked for hernial sites, you don't like an MBBS student describe in inspection and on palpation. Hernial sites are normal once for good. So they are normal now all the time. There's nothing like on inspection they were abnormal and then on palpation they'll be normal. So once you have described hernial sites are normal, there is no hernia. Finished. Next slide. Now examination of the swelling. Okay, so it's an intra-abdominal, intraperitoneal lump. And the story is over. You don't have to describe that I did head raising test, or it's not called head rising test, it's head raising, but you don't need to mention that. That's a test. You don't describe test in your description. Basically, there are ways of doing, what are the other methods of testing for whether the lump is intra-abdominal or not besides head raising?
The leg raising test.
And Valsalva maneuver. So you can use so many methods of doing it, right? So therefore, you don't have to describe the test you did. So it's an intra-abdominal, intraperitoneal lump in the region of in the epigastric region.
Okay.
Now lower half of epigastrium, upper half of umbilical region. You mentioned that it's in the epigastrium extending into the umbilical region. They don't have so much of space, umbilical region, upper, lower. And it's about 5 into 7 centimeters. Now with 5 into 7 centimeters dimension, it is going to cross 2 quadrants. One has to really see. If you had drawn the picture, maybe I would have made up. Globular shape, surface is uneven, consistency firm, margins are irregular, and it's mobile. It's an intraperitoneal lump, so it has to move on respiration as well, and it's mobile otherwise. Next, there is hepatomegaly is present or not?
Yes, sir. It's more than 13 centimeters.
Now, could you palpate the liver?
Yes, sir. 3 finger below costal margin.
Okay, so there is hepatomegaly. You don't waste time. The liver has got smooth surface, sharp margins. It's non-tender, and the liver span is 14 centimeters. Finished. The spleen is not palpable by finger insinuation test. What is that?
We insinuate the fingers over the left costal cartilage.
Sir, that is again a test.
And-
That's what I'm saying. It's a method of finding out. If there is no splenomegaly, we will ask you whether you, how did you
Not
look?
palpable.
You don't have to describe it here, right? So there is no
Okay.
splenomegaly and no other organ is involved, enlarged or
Okay.
palpable, right? Now you don't
Yes.
have to say shifting dullness is absent. There is no free fluid.
Yeah.
The moment you say there is no free fluid, somebody can ask you, how did you test for it? And that time you can describe the shifting dullness which you did. So it's not that shifting dullness is absent. There is no free fluid for which you, with that you tested by doing the shifting dullness. Correct?
What do you mean hydrated thrill?
I'm coming there. Twice and thrice you have repeated hydrated thrill. What is in your mind?
Because the epigastric mass can be due to hydrated cyst of left lobe of liver. And
You
it
already
can-
described the farm mass.
Is it, are you, no, even if you are looking at this as a left lobe, it arising from left lobe, what characteristic would be there which is missing here? It has to be a part of the liver, isn't it? So
Yes,
you
sir.
should not be able to get above this, and you should be able to get the entire fullness extending right up. That's number one. Number two, rare things are usually rare. So don't try to unnecessarily create nothing out of nowhere. And what exactly is hydrated thrill?
Yes, sir.
What is hydrated thrill, sir?
We put 3 fingers over the mass and palpate on the mid finger to locate the thrill on the other 2 fingers.
So when you're palpating the abdomen and you're trying to look for a hydrated cyst, do you think it is cystic?
Mostly.
You see,
But,
when you're palpating,
the swelling appear cystic and
now can you pay attention to what I'm saying, Rajat? When you're palpating for any swelling which
Yes,
is
yes, sir.
abdominal, you're palpating through 3 layers of the abdominal wall, which themselves are firm to even very strongly firm. And then you will be able to appreciate fluid. See, do you know even bladder is firm? And the origin of the term cystic is based on cystos from bladder. So it's a misnomer, it's a paradox. These terms are better avoided. Nobody makes a diagnosis of hydrated based on hydrated thrill. These are tests which were given in the books earlier. Clear? Even a hydrated cyst would be felt firm. It is very difficult to comment on a cyst inside the abdomen.
Better to avoid this term in examination.
You should not do unnecessary, don't buy trouble. And normal peristalsis is the answer to your, this statement. You don't have to describe it. Arterial bruit not present.
Even sir, 6 to 7 is hyperperistaltic. You see, in normal peristaltic is 1 to 2 tickles per minute. You can't say 6 to 7 is a normal peristaltic sound.
And absent. So that looks very monotonous. There is no arterial bruit. So there is no bruit heard over the swelling. There is no succussion splash. And you did ausculto percussion, which showed that stomach is not enlarged. So this lump is arising out of somewhere else. The lump should have caused some enlargement. Otherwise, why would it be palpable? Hello?
Yeah. Why did you find the greater curvature? Why did you find the greater curvature running along in relation to umbilicus?
The greater curvature was actually above the umbilicus.
Okay.
And not moving into the left mitochondria.
Now you spent a lifetime describing the DRE when it is normal. So the digital rectal examination is within normal limits. Let us ask you, what did you look for? So soft stool palpable inside, no palpable mass, no active bleeding, no palpable swelling or abscess. So it doesn't make any sense. It's an unnecessary use of vocabulary for trouble. Okay.
What could you find in the rectal examination in a patient of carcinoma stomach?
There can be any pouch of Douglas deposits,
It's a male patient. No?
some carcinoma stomach cases. There may be bleeding or hematochezia or melena, and
Look,
black stools may be
Rajat,
palpable.
Rajat, look, there is a difference in presenting your cases when you're a postgraduate student, and certain aspects are very, very basic. So when you're doing a DRE, you are looking for either another primary or you're looking for uh, any collection
Pelvic
or
deposit.
pouch in the, not in the pouch of Douglas here because you're infecting me also. In the rectovesical pouch, it's a
Yeah.
male patient. Pouch of Douglas is in ladies. And when your fingers are out, you look for the melena or any kind of hematochezia if you can. As simple as that. You don't have any of those findings, you can easily say the DRE was within normal limits. Next slide. What is this journal examination again?
Systemic examination.
So this is wrong. No, you can't use anything you want to decide. The rest of the systems are within normal limits. And there is nothing like left supraclavicular lymph node not palpable. There is no Workhouse node. Workhouse node is not left supraclavicular. It's a common mistake. But even if you want to mention that, don't have to describe not palpable. So there is no Workhouse node, which is actually the scalene group of nodes. And you are done with that. So, and the other systems are within normal limits. Now, in your summary, the hydrated thrill appears again. I don't know what is so special about it. Have you ever examined any patient for hydrated thrill? I don't know. I
Actually,
asked
yes.
Dr. Saab because
No,
I
sir.
have
I already told him this is not a relevant finding.
So this rest, I think, is just repeated is history and examination in the summary. Summaries should be some kind of a précis,
Yeah.
shorted. It should be quickly coming to the point. Let's come to the diagnosis now. So if you could have been better off giving your diagnosis with the description of the patient, anatomical diagnosis, physiological, and then the pathological. And that's how diagnosis is usually given. How old is your patient?
62 years old male.
So 62 years gentleman with an epigastric lump and features of gastric outlet obstruction. Probably likely possibility is carcinoma of the stomach. So that's how diagnosis is actually given. And now you're waiting to discuss carcinoma stomach. You must have read it all. It's supposed to be a clinical class, so we wanted to highlight those points. They are more important. Rest we can carry on discussing. I hope you understand. So 62-year-old gentleman with features of gastric outlet obstruction likely to be due to a malignant etiology, probably carcinoma stomach, as he is also present with epigastric lump. Okay.
Okay.
Why do you say it's a carcinoma of the stomach?
Because there is features suggestive of malignancy, like anorexia, weight loss, and other things. And there is no liver mass palpable separately. Liver is
No, Rajat, try to understand. You should utilize some points from history. Start with the age of the patient.
Traditionally, what the method of answering, Rajat, is there are points in history and there are points on examination. A good student who wants to pass his exam would describe it in that format. So tell us the points in history and then the points on examination which support your, this thought process. So what are the points in history?
There was a fullness with abdominal pain and then the lump. And there was associated anorexia, weight loss, and generalized weakness, which is suggestive of
giving you a hint. Age of the patient, it is important. And then there are features to suggest gastric outlet obstruction. Then there is a significant amount of weight loss and appetite. In history, that looks more like a malignant cause for gastric outlet obstruction.
Yes.
And the one that you know is a carcinoma of the stomach. It was one of the important ones. Then what are the points on examination? In general examination, loss of, he's malnourished. He's got
Pallor.
pallor is present. Then examination of the abdomen, hard lump,
palpable mass on abdomen,
irregular surface, and there is its location is suggestive. All right, and associated hepatomegaly, although you did not mention or did not suggest that it is a metastatic hepatomegaly, so we would still consider it to be relevant. And these are the features which will make you think in terms of a malignancy, and that too of, a gastric malignancy, carcinoma. Is there any differential diagnosis? Hello?
hepatocellular carcinoma.
Now see,
Don't jump. Don't jump.
I would not take you anywhere from here. First of all, you should be clear on what organ is it. So if you think it is stomach, then it is not liver. You already decided that because the swelling is separate from liver.
Yes.
So you cannot unnecessarily bring in liver now. So it's not just for the heck of it, you will start saying whatever. Just because you have gone some distance, you think it is malignant. Is that okay?
Any other
Yes,
lump
sir.
in the epigastrium, which may be from the stomach?
Subacute perforation of peptic ulcer.
Oh my God.
1 month history, peptic perforation. How can you do that?
Not
Give some relevant
possible.
diagnosis. Apart from carcinoma stomach, can there be any other mass in the epigastrium which might be related to stomach itself?
No, 1 minute, Rajat. What did you say? Subacute perforation of?
Gastric ulcer.
Where did you hear it from? Subacute perforation.
Some concealed perforations can look like mass, but this is not actually a proper.
You should bring some DD which are relevant to your presentation. Is a chronic presentation with anorexia, weight loss, this no acute pain abdomen? So why do you bring this? You think of some other condition in the stomach. Any other lesion in the stomach which may present with lump?
Pyloric stenosis, maybe
All right, you're not able to think. So first of all, you think it is a malignant lump? Hello?
Yes, sir.
So do you think it's a malignant lump or a benign lump?
Malignant lump, sir.
So let's look at some differentials in the malignancy and then rarely into benign. Forget about any other organ because then you would be completely all out of place. Okay, because the organ is clear to you. If there is any confusion, then you can tell us. In that region, is there any other organ which can present like this?
Pardon, sir.
Any other organ which can cause such lump? What is another gut content in this same region which can present with the lump?
Transverse colon.
Transverse colon, yes.
Transverse colon.
Yes, and I'm glad
pancreatic
you
cyst.
No, don't say that. I was waiting, you will do that. It's an intra-abdominal, intraperitoneal lump. So differential diagnosis of an intraperitoneal lump should be another intraperitoneal lump. Right? If it is a pancreatic malignancy, it won't be moving on respiration. It would be retroperitoneal. So don't compare an apple to an orange. So it's an epigastric lump, which is intraperitoneal, lying in the region of the stomach. Yes, transverse colon is a possibility. Otherwise, you'll be just stretching it unnecessarily. It is unlikely that you'll have any other lump, any other disease presenting there. But when you're saying malignancy of the stomach, there can be some malignancies of the stomach which can present like this. But the patient also have features of gastric outlet obstruction, which would mean it's an intraluminal growth. So likelihood of carcinoma stomach is so high that others would be rare to be considered. So you can
still I think, sir, he can place a GIST or a lymphoma in the stomach.
Oh, I mentioned that. Say if you say GIST, the patient would have intramural symptoms are not early or not common. But
Yeah.
patient has those features of gastric outlet obstruction. Therefore, it was necessary to mention in the beginning, my patient had a 62-year-old gentleman with features of gastric outlet obstruction likely to be due to a malignant cause, probably carcinoma stomach. Now differentials can be rarely all these conditions. Say GIST is one, lymphoma is another, which is now more of a diagnostic surprise. But this is more what is likely to be your diagnosis. All right, how do you proceed now? So I hope you understand, Rajat, and other students also. Now you cannot bring in liver, you can't bring in pancreas, you can't bring in other organs. You have made an very, very clear diagnosis. Sometimes it is rare. I say splenic mass. You're looking at renal, then you ask questions, how do you differentiate the two? But in this case, you can't link it to liver especially, right? And therefore this highlighted thrill, now I understand. You are trying to think of something related to liver.
Yeah.
You must make it a point that your lump is different from the liver by mentioning that you could find that space between the two, and hepatomegaly is present, which is separate from this. So you can't have a huge lump coming out as a nodule from the liver while you could get above it, etc. So be careful on that. So don't try to confuse your own progress in history and examination by bringing in different organs now. Let's go. How do you proceed? What do you do? Yes, your working diagnosis. We have 10 minutes.
What are the
Now
steps?
to proceed, we can do we have to further investigate the patient and some routine blood investigations
Off.
and some
is not the way,
imaging
one, sir.
investigations.
Actually, you see, Rajat, it is always good if you're going to present today. A good student would be looking for all these presentations already existing on YouTube. There are plenty. And you do investigations to confirm the diagnosis, to support the diagnosis, to stage the disease, and to treat the patient. And none of these hemoglobin, TLC, DLC, etc. would be confirming your diagnosis.
So come to these points. Tell us the investigation to confirm and support the diagnosis.
Rajat?
Contrast in
Oh, that is not the first diagnosis.
and upper.
Rajat, I don't know if we are wasting time, but I think every time I feel it's a time well spent because they are all types. You would just not understand if you don't want to. You're just wanting to finish this case. That is not how you will learn. Investigations to confirm the diagnosis are not different from what you usually do in your clinic. What will you do in this case? If this patient comes to you in your OPD, he has come today. What would be your first imaging?
You see, no harm saying ultrasonography in all patients. It's an extension of clinical examination. So you can always say ultrasonography. That is, no examiner will deny that you won't do ultrasonography.
Absolutely.
Okay,
It's a mandatory part. Actually, why should ultrasound be done before you do anything else, Rajat? Hello?
Yeah.
Is he there?
Yeah, he's
Yes,
there.
sir.
So you keep responding, Dr. Rajat. Your camera is also off. You're exerting. So as an extension of clinical examination, I would like to do an ultrasound which will let me know whether this is the organ of origin that we are referring to. How is the liver? What is the position of the lymph nodes? Is there any free fluid? All that you have described in clinical examination can be confirmed here. Once you know it's arising from stomach, then you can proceed to some definitive investigations. Suppose you go ahead with other investigation and you find the lump was not arising from stomach. You put in an endoscope and you find it's not in the stomach, then you'll be mistaken. If it is a GIST, you may not get much finding from inside. So therefore, it will depend on your initial ultrasound. And an ultrasound, as mentioned correctly, is an extension of clinical examination. Okay. Now, hello.
Okay.
Yeah. So
Yes, sir.
So then you've done an ultrasound, and now you'll do upper GI endoscopy. What is the purpose of doing upper GI endoscopy?
To look for the mass and take biopsies from the lesion
So you can,
if there is any intraluminal mass.
you can go a step further. If there is an intraluminal mass, you can take a biopsy, and that is what will actually confirm the diagnosis. If you find that your examiner stops you when you say ultrasound to confirm the diagnosis, you may say ultrasound cannot confirm the diagnosis. So that's where you will bail yourself out by mentioning it's an extension of clinical examination. And start that way. I'm just doing clinical examination, and ultrasound can be an inexpensive, non-invasive investigation to find out the organ of origin. Once you've found out the organ of origin, you can do upper GI endoscopy. But this is a big enough lump, so you cannot add endoscopic ultrasound, etc. So don't just unnecessarily add it when it's not required, not in such a case. Okay, you heard of it? Endoscopic ultrasound?
Yes, sir.
Would you need to do an ultrasound in a patient who has got already a palpable lump?
That's what I told him. So since that I've already answered for him. So you don't mention it as a routine in all the cases. Clear? So you've done an upper GI endoscopy. It's a large lump.
Okay, sir.
You take a biopsy and you have a working diagnosis. What next you'll do? So I told you investigations to confirm the diagnosis. You already looked at it. To stage the disease, what will you do?
Whole body PET CT scan
That is not the first thing.
is needed for to see a gastric.
Oh, Rajat.
We
Wait.
have a point to present in the clinics, dear.
No.
No, I'm stopping you because all your answers are simply reflecting that you don't clinically look at all. Who will do a PET scan next investigation? You will be working at, you mentioned that also, contrast and CT scan earlier. So that comes here. That's why we were asking you, right? And you do a CT to look for what? What all information you would gather?
Any intra-abdominal metastasis?
No, before
Any
that,
serosal
before
invasion,
that,
any
before
peritoneal
that,
deposits?
primary mass.
I
to
think the
understand.
problem, Dr. Shah, is
Primary mass,
they are on their own. That is why they keep doing all sorts of things. They
You
observe around.
see, CT is for staging of the primary. CT is for looking for nodes. CT is for looking for distant metastasis. So be
The
methodical in answering.
Whole thing is the entire story. Rajat, pay attention, please. We are spending early morning time with you. The whole story is about T, N, and M in history, in examination, and on investigation. So for T and M, for T, you've already done some bit. Ultrasound also tells you about T, N, and M. CT tells you more clearly. So the tumor, that is primary, the lymph nodes, that is metastasis, and distant metastasis. Ultrasound will also tell you about liver and ascites and prefluid, but CT will tell you better. So CT is staging for all three. So it's not for distant metastasis only.
Okay, sir.
Clear? So in any malignancy
Okay,
that
sir.
you next time present in your class, not stomach, any malignancy, take the history of TNM, do examination for TNM, do investigations for TNM, treat them for TNM, and observe them, follow them up for TNM. That's the story. TNM is the story of any tumor. Now, you've done these.
Rajat, what intraabdominal metastasis you can miss on CT scan? Even a good quality CT scan? What intraabdominal metastasis you can miss?
Pancreatic malignancy.
No. Patient has carcinoma stomach.
Okay,
But
sir.
what are the lesions which are metastatic can be missed on a routine CT scan?
Krukenberg's tumor, if you can see other missed on CT scan.
Can this person get Krukenberg's tumor, Rajat?
No, never.
So why should we talk something which will provoke the examiner unnecessarily? He's
This
asking
is
you on CT what metastasis can be missed.
small peritoneal metastases, small omental deposits. Okay, these are the lesions which cannot be picked up. Any lesion in the liver which is less than 3 millimeter cannot be picked up.
No, size is a constraint. Now, and which is the best CT available that can take it up to 3 mm?
Triphasic CT scan and other phase.
You see, you are basically looking at cutting thinner sections, no? Your head. So read about it. Now, coming to your staging. How do you stage carcinoma stomach?
A CT chest should be part of staging workup, Rajat. In a patient who has got such large lump, CT chest should be a part of the workup also.
Yes, sir. CT chest, abdomen, along with the bone scan if needed.
Chest, abdomen, pelvis.
No.
So is bone scan a routine
No.
metastatic workup for stomach? It is
No,
not.
sir.
So
Not.
when it's not, why are you mentioning it? And so CT chest, abdo, pelvis. Pelvis is especially in ladies for the ovary, Kuchenberg's, and also pouch of Douglas deposits. And as Dr. Shah was mentioning, very small lesions. So you have, the thin slices that you look at. And what other investigations you can do to stage it? You mentioned PET scan. What are its advantages and limitations?
Advantage is that it can look through for the whole body and any metastatic deposits anywhere, except there are some physiological hypermetabolic areas like brain, the prostates, which we can miss.
And
What type of carcinoma we missed in PET CT?
The FDG non-avid tumors can be missed, like
What?
neuroendocrine
Which
tumors,
tumors are non-avid? In the stomach.
neuroendocrine tumors,
Huh?
neuroendocrine tumors.
We are talking of carcinoma stomach.
Mm.
What type of carcinoma stomach patient may have a situation that is non-PET avid?
And GIST,
Mucinous carcinomas, signet cell
mucinous
carcinomas.
sorry, what do you mean by mucinous and what do you mean by signet cell? Sorry. Signet cell is like a ring, no? So when there is a lot of glucomucin or mucin, the nucleus is pushed to the periphery. So that looks like a signet cell. So they're similar. They're the same thing.
Yes, sir.
So they don't have the kind of activity you need for it to pick up. Yeah. So any tumor which is not active or it's not, multiplying quickly and not consuming that glucose, you won't pick up the PET. PET won't be picking it up. How do you stage carcinoma stomach? Means what is the AJCC 8th edition staging? PNM staging. You can read it. I think that
the tumors.
Do you know or you don't know?
What does the T3 stands for? Just tell us one. What does the T3? What do you feel? This patient has got a tumor which is T2 or higher? This patient.
This is a T tumor.
What do you think?
This is more
Patient
than
has
5
got a
centimeters.
palpable lump. Is a T2 or less or higher side?
Higher side, because
Higher side.
it can be
Because you
very
say
serosa.
palpable lump means it is almost going up to the serosa. Otherwise, it's likely to be impalpable.
Definitely, it will be a locally advanced one. And you're not looking at anything which is within the range of 2 to T2. It's beyond that. Now, so you know about it. T3. What is T3?
Serosal invasion with without invasion of visceral peritoneum.
No, it
Visceral
is serosa.
peritoneum invasion is T4.
What is serosa, by the way? Is it a part of
the
only? There's no serosa.
peritoneal,
So,
the peritoneal layer.
So it's a peritoneal layer. It's the visceral part. Anyway, so what about the nodes? How do you stage? I think read it because we would be otherwise telling you.
Nodes are now based on there are different stations, but now the CS stomach is staged based on the number of nodes being positive. That indicates that it is either a first tier of nodes and the second tier of nodes. Okay, so you should be knowing the different stations of node which drains stomach.
All right, what do you think would be the likely management in this case? We have 2 minutes. I think we have done. It's 9 already.
Distal gastric.
Yeah.
We do.
You go for upfront surgery
distal
or
gastrectomy
in mind?
with
All right, what make it non-detectable?
there may be what's that?
What would make this disease non-resectable?
Non-resectable disease if it's metastatic to liver or there is multiple metastasis, or if there is any invasion of underlying pancreas or surrounding structures.
Is there any role of any neoadjuvant therapy in carcinoma stomach?
Yes, sir. We can go through the neoadjuvant chemotherapy
You can, or it is an
for
established,
4 to 6 cycles.
you can go, or it's an established regime now for CS stomach. What do you think? Is it an established modality of treatment?
Yes, sir. Mostly people go through neoadjuvant, but I have seen some patients to undergo neoadjuvant after surgery.
Any different upfront surgery, people are doing
After
different.
surgery. Upfront surgery is done in very rare scenarios. You can do it, and there may be an indication here. Could you tell me what would be prompting somebody to go for upfront surgery here?
When
Obstruction.
is the upfront surgery indicated? Indication, you are right. You may do, but
Obstruction, then you don't have a choice. You can't delay gastric outlet obstruction. But there is a protocol for nuclear stomach malignancies where you put the patient on neoadjuvant chemotherapy, and that is what is done. And
Yes, sir.
you may not be able to get an R0 in a lot of these patients. You have to therefore resort to neoadjuvant chemotherapy. Does it have an impact on survival? One doesn't know. The disease-free survival, yes. Overall survival, no. And your approach should be, at least you should be able to highlight those points. The examiner should get an idea that you know what is actually required. Although the best treatment is still surgery, but we do resort to these neoadjuvant protocols in these.
Neoadjuvant.
Yeah. Now, what did you say when you're doing? Suppose it was a resectable tumor and you've decided to go for upfront surgery. What surgery would you offer? Last 1 minute.
Distal gastrectomy.
what? Only gastrectomy, or you want to add something with that?
When you say
Posterior gastrojejunostomy.
Rajat, when you say distal, what do you mean by that?
The distal part of stomach covering pylorus antrum of the distal part of body.
So your answer should be, it will depend on the extent of the disease, right? So you can't decide beforehand. And secondly, is it a benign lump or a malignancy? It's a malignancy. So what do you do for malignant diseases? Radical, no? You will be doing radical gastrectomy depending upon the extent of the disease. What margin do you take proximally and what about distally?
Approximately a 5 centimeter margin is taken.
It will then depend, no? Whether it is, you can do distal or you'll have to resort to doing
subtotal,
right? And what about the lymph node, the dissections? That is D1, D2, any idea about it?
And D1 is just in the side of stomach.
Not perigastric.
Perigastric.
What are the stations?
Right and left cardiac, along the lesser and greater curvature.
Name them.
And
1, 2, 3, 4. Is that what you're saying? Next.
1 and 2 are right and left cardiac nodes. 3 and 4 are left. 3 is lesser curvature. 4 is along greater curvature. 4 is divided in 4 A, B, C.
Then 5 and 6 are?
5 and 6 are supra and subpyloric lymph nodes.
Yes. So they are the first tier of nodes.
First tier of nodes. And mostly we do D2, going up to 7 to 11. 7 is left gastric artery lymph nodes. Then 8 is common hepatic artery.
Right.
The 9 is along the celiac axis route. And then we go along the greater curvature to look for splenic hilum and splenic artery lymph nodes from behind the stomach.
All right. So if you were to just palliate this case,
yes, sir.
Patient has just got obstruction and you're resorting to just palliative surgery. What are the options?
We can do a gastrojejunostomy, but mostly the mass will be invading the gastrojejunostomach and it will further cause obstruction maybe in a later part.
What is the best palliation? What is the best palliation?
We mostly do a feeding jejunostomy, but the best palliation would be a metallic stenting through the pylorus so that the obstruction can be relieved.
Best palliation is resection. If it is
Resection will
resectable.
give you palliation in, remember, for stomach and for colorectal, the best palliation is still surgery. When you get the tumor out, you get the cachexia out. So cachexia disappears, bleeding problems disappear, obstruction disappears, but you should be able to resect. That's the only catch there. Now,
Okay.
Okay, sir.
if the patient had a Werkhouse node positive and this was the picture, how would you approach it?
What is the
That means,
stage?
the stage will be 4. It will be distant metastasis.
So,
You do upper GI endoscopy or FNAC from the node?
Imaging guided core biopsy would be better.
All right, image guided core biopsy of the lymph node, but you will still be doing upper GI endoscopy. That's what I wanted to say. You can't ignore it, you can't exclude it, but yes, the patient would get palliative or the therapy with a palliative intent. Should we close, Dr. Shah?
yes, sir. Anything, do you know any newer marker being studied in this pathology specimen?
Tumor CA15-3 or other specimen. No. CA 125 we assess.
CA is a routine serum marker.
99.
Suppose this was a resectable tumor, Rajat, and you are
Yes, sir.
planning surgery. Can you take us through the steps? What will you do? You're planning it today, morning.
Will you upfront
Yes,
go
sir.
for laparotomy or do something else in between?
Diagnostic
be direct with
laparoscopy
you.
may be done initially
So that's
to
called
look for
staging.
environmental
That's called staging laparoscopy.
staging laparoscopy. Staging laparoscopy.
What Dr. Shah was mentioning you would miss on CT, they can be picked up on laparoscopy.
Laparoscopy.
Therefore, it makes sense. And is there a possibility that you can abandon surgery after that? Yes, it's possible. And if you find peritoneal deposits, you'll take a biopsy, send it for frozen, and you can stop surgery. But you'll still have to do something about this obstruction. So you may resort to it as a metastatic disease. The intent would change. You won't be chasing the lymph nodes now. You won't be doing the D2, D3 or D1, D2, whatever. You will just see that you can get the primary out somehow and palliate this patient, right? Do you have any question, Rajat?
No, sir.
So I think you can go back and watch this yourself and see what you can add and improve. I think you did a good job, but importantly, please watch others.
I need to improve on many
mistakes. All right. So thank you very much. Thank you, Dr. Shah.
Thank you, sir. Thank you very much.
Pleasure.
Thank you.